Here we go. Thank you for that kind introduction. I don't know if I'll live up to guru status, but I'll do my best. Let's see. I think this is working. So here we go. Therapeutic contact lenses for corneal ectasia. I have only this disclosure with Tech Lens. I'm here maybe preaching to the converted, but to tell you that a specialty contact lens is a new field within the United States optometry. Optometry graduates can do a residency in contact lens. This residency happens after 4 years of university education and 4 years for a doctorate in optometry. So it's a longer training than in most other countries around the world. And then this cornea and contact lens residency is an additional year. There are about 24 spots nationally. There are also residencies in ocular disease, and some of our specialists in therapeutic contact lens come through that route as well. These optometrists typically train and work collaboratively with ophthalmologists in an integrated model of eye care. And this is the pattern in which, let's say, Dr. Hessen and Christina Prescott practice together at Wilmer. Globally, the delivery of this type of care depends on the scope of practice within each country, as it varies from country to country, whether they're optometrists, orthoptists, or opticians fitting contact lenses. The specialty contact lens area is a growth area in the contact lens industry globally, whereas much other contact lens sales are pretty flat. So I think I explain all this because I want ophthalmologists to be aware of this innovation in specialty lenses that may be different from even a decade ago for those who trained more recently. So what are the specialty lenses? There are RGP corneal lenses, the Keratoconus design specifically. There are piggyback systems, Silicone-Hydrogel, hybrid lenses, Scleral Lenses, and then the highly customized lenses and scleral prosthetic devices such as a PROSE. So to go through them quickly, the corneal lenses, the Keratoconus designs are what are commonly called Rose K lenses. People think that encompasses all of them, but actually that's just a brand. There are too numerous to name, many, many others. The newer ones have innovative base curves to accommodate the shape of the cone. And some of them have innovative optics now that can neutralize the characteristic decentration and coma that occurs in keratoconus. Their back surfaces can be toric, so those are called dual aspheric designs where the front and back can be aspheric. They have increased stability and comfort. And there's literature from the last decade or so showing that using this dual aspheric curve, you can have a greater likelihood of more than 12 hours a day of wear. Now, a piggyback is a hard lens worn over a soft lens, and there are infinite varieties and combinations. There can be soft lens with plus that stabilizes the RGP, with minus to flatten the apex and reduce the power required, or they can have a carrier feature that the lens sits in. The problem with all of these arrangements is that the double lens contributes to hypoxia because there's more material to go through, and often to accomplish the stability, the lens has to be thick, either in the center or periphery, which each can create different hypoxic challenges. The newer high decay materials are helpful, but again, hypoxia, handling issues, and complicated care regimens are a challenge. There are new custom Sihy soft lenses that folks aren't aware of that can be used in keratoconus. And a few brands are listed, the Kerasoft, the Novacone. I don't know the names of the brands in Asia, but I imagine these are available. They have some interesting features. They're a little larger than most soft lenses, rigid modulus. They're all high DK. So they create a mini vault, and they can be customized to sit properly on the eye. And here are two more recent publications about these lenses from Spain and Turkey, respectively. And these allow some keratoconic patients to stay in soft lenses longer. And that's a big plus. So you're not going to use these for the most advanced cones, but for patients who were already soft lens wearers, maybe were in torics, and then someone figured out it's KC and not plain old astigmatism, we can often buy more time with this category of lenses. So they definitely have a role, but they require some expertise on the part of the fitter. So it's a big advance over toric soft lenses. Now, hybrid lenses can also be used in keratoconus, and there's publications from the US and Spain on that. They're definitely an advantage over RGPs because they're stable and the patients don't feel the edge. They now are different designs for keratoconus, for post-op astigmatism, for post-refractive surgery, and they have different features as to the design. These are high DK, but unfortunately, they develop what I call a non-physiologic fit. They adhere and have suction, and so patients get into problems with adherence of lens, ulceration, and sometimes new vessels related more to the mechanical issue than pure hypoxia. I'm going to finish up with a little extra attention on scleral lenses, near and dear to my heart. I was part of the team that helped increase awareness, availability, and appreciation for PROSE lenses. I was at Boston site for over a decade, although I have not been affiliated for several years. I highly recommend this online free text, which is a guide to scleral lens fitting. These days, we just use Scleral Lens to talk about any lens that runs about 15 to 18 millimeters, and the distinction between minis and corneosclerals is falling away, although I believe there are distinctions, but from a marketing purpose, it's easier to call them all sclerals. And I've listed a few brands, but is by no means an exhaustive list. The goal with these is to achieve a scleral fit that is no corneal touch. I think that the ones that are smaller diameter seal rather than are fluid ventilated, and sclerals that seal may develop suction, clouding of the reservoir, haze, and if the vault is too high and it's sealed, there may be a tendency toward hypoxia. What isn't discussed much is that some of these smaller lenses have a narrow bearing zone at the limbus, and particularly for ocular surface disease, grafts, challenged eyes, there may be complications. And this was recognized early by colleagues in LA who published on their experience with mini scleral lenses. So now there is generally increased awareness, acceptance, and availability of scleral lenses. I guess my work at Boston site succeeded. Muriel Shornack did a very, very excellent scleral lens literature review in 2015 that I highly recommend. And now there are increased number of clinicians who are comfortable fitting these lenses and growing acceptance as an option for corneal RGP lens intolerance and keratoconus. So in the bad old days, the doctor would diagnose keratoconus, send them to a lens fitter who would put them in RGPs for as long as the patient or the fitter could tolerate it. And then when that didn't work, they went back to the surgeon, had a cornea transplant. When they didn't see well, they went back for RGP lenses, back and forth, back and forth, back and forth, and nobody was very happy. Scleral lenses and PROSE have changed all that. And here are publications on the Jupiter lenses from nearly a decade ago, 2 different centers in the US. PROSE, which Dr. Hessen described beautifully, was developed at Boston site. And in the interest of time, I'm going to click through all of this since you know about it and I'm running late. Basically, in 2010, we published our 2006 experience with PROSE across all diagnoses, and there was huge improvement in vision, 5 lines roughly for ectasia and astigmatism, 2 lines in ocular surface disease. It's not that it doesn't work for ocular surface disease, but what there's called is a ceiling effect, where if a patient comes in with SBK and 20/40, they can't improve 5 lines. There's only 2 lines to go. So basically, huge impact in acuity, and most important, more than 20 lines improvement on the NEI-VFQ, and that was regardless of whether this was ectasia and astigmatism or ocular surface disease. A few years later at Boston site with a group of colleagues, we reviewed a 6-month cohort just with keratoconus, and we studied the results of 89 eyes and 59 patients. Same scale of improvement as we found in a cohort 2 years earlier, but most importantly, we showed that 88% of the eyes were wearing the device at 6 months. This is a huge success rate for a specialty lens in advanced eyes. The interesting thing we found is that failure did not correlate with the steepness of the cone because of the vault control that Dr. Hessen described. You can raise the height of the lens over any cone. No cone was too steep to be fit, and grafted cones could also be fit. And for those of us who fit these eyes, we know that the problem is out at the graft-host interface where there is continued ectasia, and ordinary sclerals would bear down there, but with PROSE, you have a substantial vault control, and you can deal with this peripheral thinning. Then to get out of Boston site itself, there emerged data from a PROSE site at the University of Michigan, Kellogg, and they looked retrospectively at PROSE versus keratoplasty for ectasia. They looked back at 2 years at a single site, had 37 eyes in each group, which was by coincidence. It wasn't a design study. That's how many fell in each group of patients with advanced keratoconus referred for either PROSE or keratoplasty. Any eye sent for PROSE could be fitted. The vision was better and it was faster to get there than after PK. And there were fewer complications than after PK. And there were some DOC patients included in that cohort as well. Since then, from Belgium, Karina Kampen and colleagues reported their experience and found retrospectively that scleral lenses reduced the need for cornea transplants. And they found that the need for keratoplasty in these patients with advanced disease was halved. And again, this year from colleagues again in Michigan, looking retrospectively, they found that referring keratoconic patients for scleral or RGP contact lens reduced the risk of keratoplasty by 80%, putting the surgeons out of business. Maybe we don't want to hear it, but it's doing that. And interestingly, that the need to go ahead with keratoplasty wasn't associated with the maximum K. That is, there were other factors, often socioeconomic, that had to do with who ended up getting keratoplasty. It's disappointing that it was disproportionately young Black men. I'm not sure what that says in our society, but it probably does say something. There's no data yet on iPrint Pro, which is molded and then undergoes a digital custom design. Hopes are high that this would help with RGP corneal failures, but there isn't a single source of good longitudinal data on keratoconus with this modality yet. Further considerations: keratoconus patients can attain good vision despite axial opacities. This is a 20/25 eye in PROSE lens. And this would be a bad case for keratoplasty. There are peripheral vessels and there's ongoing atopy. So the new algorithm is that you really should assess vision in a specialty lens before deciding for surgery, even if the pupil is obscured, because the reduced vision may be mostly optical and not media. Furthermore, high drops can be rehabilitated with a scleral lens. In some places, patients who have high drops are told they're not going to recover good vision. They go right for keratoplasty. Many of them do recover good vision. They flatten sometimes after high drops, and they can still be fitted with a scleral lens. And again, this has been published by colleagues in Antwerp. It's my own personal experience, and hot off the presses, there's experience of this coming out of India. Finally, scars can remodel when surface barrier function is restored with a PROSE lens. And this is at the top a woman in her 50s who wore every manner of specialty lens for keratoconus and ended up looking like that, which would not be great prognosis for keratoplasty. And after 4 years of PROSE, she was 20/25. Vessels and haze had regressed. And this is work we published from Boston site nearly a decade ago. So keratoplasty for keratoconus is a paradox. It's generally successful, but there's low patient satisfaction. Why is that? Well, they compare with the fellow eye. They compare with their historical RGP vision, which is excellent. There's a high rate of graft astigmatism, even typically 4 diopters, even with excellent surgeons and even with DALK. Up to 40% of post-ops are contact lens dependent in keratoconus. The new paradigm for keratoconus, and these are my clinical pearls, is to consider that a patient's not a contact lens failure without trial of specialty lenses. The new designs and materials are more comfortable and give a physiologic fit. There are good examples of why each of these can help. And finally, that large scleral and PROSE treatment are successful independent of steepest K. So I don't need to know what the K is to say whether PROSE will work. Doesn't matter if it's 70, it will. And the main message is no graft for keratoconus without a trial of specialty lens first. There's an editorial from Ophthalmology, 2016, showing that PK is decreasing in the US, partly because of shift to DSEC and DMEC, partly because of earlier referral for cross-linking, which is delaying or eliminating the need, but also realizing that there's increased acceptance of specialty lenses as an option for contact lens intolerance. New paradigm, a patient is not a contact lens failure without a trial of specialty lenses. Thank you very much. I'm sorry if I've run over, and I look forward to answering questions at the end.